მოგესალმებით ძვირფასო კოლეგებო, ძვირფასო მეგობრებო, ჩვენი ასოციაციის წევრებო და მონაწილეებო. ჩვენ წლევანდელი, ესე იგი წელი დავიწყეთ სემინარებით, რომელიც იქნება ძალიან დატვირთული სუპერვიზიებით, სემინარებით, სამკითხველო ჯგუფებით, კიდევ უფრო მეტად, ვიდრე ეს იყო წინა წელს და დღეს გვაქვს პატივი, რომ მოусმინოთ და მოვიწვიოთ ალექსეი ტოლჩინსკი, რომელიც ამჟამად მოღვაწეობს შეერთებულ შტატებში, კერძოდ მერილენდში, სადაც და მე მას დიდი ხანია უკვე ვიცნობ, არა მხოლოდ მე, არამედ ჩვენი კოლეგები, სადაც ის მოღვაწეობს როგორც კლინიკური ფსიქოლოგი, ის არის დოქტორი კლინიკური ფსიქოლოგიის, მთლიანად ფსიქოანალიტიკური და ფსიქოდინამიკური მიმართულების და რაც ყველაზე მნიშვნელოვანია ამავე დროს, ის არის სპეციალისტი, რომელიც იკვლევს ნეიროფსიქოანალიზს და ნეიროფსიქოანალიზთან დაკავშირებულ საკითხებს, რომლებიც არის ერთ-ერთი ესე იგი, რომელიც არის თანამედროვე, ასე ვთქვათ, მიმართულება ფსიქოანალიზში და ძალიან ბევრ ფუნდამენტურ საკითხს სვავს, რომელიც დაკავშირებულია თავის ტვინთან და ფსიქესთან და იმ გადაკვეთის წერტილებთან, რომლებიც შეიძლება ფსიქეს და თავის ტვინს ჰქონდეს. ალექსეი ტოლჩინსკი იბეჭდება ძალიან ბევრ ჟურნალში და მისი კვლევის საგანი არის ადაპტაციასთან დაკავშირებული საკითხები, კომპლექსები, მიგრაციასთან დაკავშირებული საკითხები და მძიმე ტრავმასთან დაკავშირებული საკითხები და ტრავმატიზმთან. ესე იგი, ტრავმატიზმის საკითხი როგორ შეიძლება გაშუქდეს ნეიროფსიქოანალიტიკური პრიზმიდან. და ალექსეი თანახმაა და მას მინდა ამისათვის მადლობა მოუხადო. თანახმაა, რომ მე მგონი იანვრის თვეზე შევხვდით, თუ არ ვცდები, რომ წაიკითხოს მან მეორე ლექცია ჩვენი ასოციაცია ქართული ფსიქოანალიტიკური სივრცის ფარგლებში, ნეიროფსიქოანალიზი და მძიმე ტრავმა. რაც ყველაზე მნიშვნელოვანია, ის არის ასოციაციის ნეიროფსიქოანალიტიკური ასოციაციის დამფუძნებელი, ერთ-ერთი და კლინიკური მიმართულების ხელმძღვანელი. ამ ასოციაციის იდეა იყო, რომელსაც ადრე ერქვა ნეიროფსიქოანალიზი რუსულად. ამ ასოციაციის მიზანი იყო გაერთიანებინა ყველა კოლეგა ამერიკიდან, მისი კოლეგებიც ამერიკაში მოღვაწეობენ, პოსტსაბჭოთა ქვეყნებში, სადაც რუსულად ლაპარაკობენ. შეიძლება იყოს რუსეთი, მათ შორის ცხადია, უკრაინა, სომხეთი, აზერბაიჯანი, ბელორუსი, ყველა ის ქვეყანა, სადაც ერთი საერთო ენა შეიძლება და ყოფილიყო რუსული. ეს ერთ-ერთი მიმართულება ჰქონდათ და მას ჰქონდა თხოვნა, რომ მოგვეძებნა საქართველოში სპეციალისტი და კოლეგა, რომელიც წარადგენდა ამ ამერიკულ ასოციაციას საქართველოში ნეიროფსიქოანალიზის და ასე ვთქვათ, ამ კონფერენციების ორგანიზებას გაუძღვებოდა. და თუ კი ვინმეს ექნება ამის სურვილი, რა თქმა უნდა, შეგიძლიათ მიმართოთ ალექსეი ტოლჩინსკის პირდაპირ და ის თქვენ დაგეხმარებათ. ამ ასოციაციის საიტზე არის უამრავი ლიტერატურა, ბიბლიოგრაფია, წიგნი, ვიდეო და აუდიო ლექციები, რომლებიც ყველასათვის არის ხელმისაწვდომი ცხადია, იმიტომ რომ ეს არაკომერციული ასოციაცია, როგორც თქვენ. აი, მადლობა კიდევ ერთხელ და დანარჩენი თქვენიცით.
Well, I'll try to translate you what Giga said. So he greeted us, all the participants, and he said that we now start our annual seminar is opened of our analytical association. He presented you as a neuropsychoanalyst. And that you are interested in this sphere. You study psyche, adaptation, complexes, migrations, traumas, and so on. That you were so kind that you said that you will have another lecture with us in January and about neuropsychoanalysis and trauma. so that you are founder of the association. The aim of this association in America is to enclose Russian-speaking analysts and interested in this field people, and so those in Georgia who are interested in this sphere, they can address you, they can address your site and have relations with you. Giga thanks you for your being here with us. This is shortly what he said.
Of course. Well, thank you both. Thank you, Nino. Thank you, Giga. If I may just say a couple of corrections, I am not a founder by any measure. I've joined neuropsychoanalysis about 8 years ago, but it was founded by Mark Solms in London in 1999. I'm not an analyst. I'm just a clinical psychologist, a dynamic clinician. In the States, it's very strict. You know, if you've graduated from a full psychoanalytic institute, you are allowed to call yourself an analyst. I've graduated from a doctoral program, so I'm a licensed doctoral level clinician, but not an analyst. And we are very democratic in our Neuropsychoanalysis Association. Anybody can join. Not psychologists, anthropologists, philosophers are welcome to join. We do have a clinical certification if you are a clinician and allowed to practice in your country. But thank you so much. I just wanted to ask Giga, is it okay for me to do now I can do screen sharing. Thank you so much. Okay, let me see if this works. And Giga, may I ask you if we can see the slides?
Yes, yes, we can. Okay. We see.
All right. So I will talk for about an hour. I'm not attached to the slides. Feel free to stop me anytime, ask me any questions. If you would like, I have a short case at the end. We can go through the case or not to illustrate. And I would like to talk to you. Maybe we'll have a discussion, a Q&A at the end. So I'd like to leave some time for that. And without further ado, I'll just dive in. But if I'm talking too fast, too slow, interrupt me, stop me, and I'll do that. Is video, audio, sound working? Everything's okay? Yeah, okay. So why don't I start? So I'll talk briefly about the history of neuropsychoanalysis, why it was developed, and why use it, because many people have practiced analysis for a long time, and they're like, we don't need any prefrontal cortex, thank you very much. And truth be told, not always you can consider using it. It's not for everything. It's not a panacea. We'll briefly talk about our models. We'll talk about effective neuroscience by Jaak Panksepp, and maybe a clinical case in discussion. I'd like to start by a metaphor. Those of you who have been in the caves have seen these structures, the stalagmites and the stalactites. When I was studying in my program, we had biological theories of depression, such as monoamine theory of depression with serotonin. That theory is actually going to be retired pretty soon for many reasons. And right now at NIH in Bethesda, 20 minutes from where I live, people are developing the new theories with glutamate and ketamine-based medications that are specifically designed for very difficult cases of depression, vegetative, chronically suicidal cases of depression. But in any case, these are theories bottom up. They're going from the neuronal level, from neurotransmitters up to the mental functioning. And Freud developed top-down theories, such as his famous paper, Mourning and Melancholy, which is an inference. It's sort of observing clinical practice and modeling how depression works. But, we still, despite depression being one of the oldest conditions in history, we do not have a unified theory of depression anywhere close. These little models are all islands. They're not connected to each other in any way. And when the patient walks in the door, they have biology, they have psychology, and unfortunately, we don't think this way, right? So there is a need to bridge the gap. There is a need to connect the two. In addition to that, if you open diagnostic manuals such as ICD or DSM, you will find a lot of statistics and you will find agreements. A group of clinicians got together and decided to call this thing major depressive disorder and that thing bipolar disorder 2. but there is nothing in terms of etiology, in terms of why. How does depression come about? There are again theories about it with a little bit of genetics and behavior and loss, but not really anything specific. Other theories are arguing whether depression is indeed a disease, and we should apply medical model, such as malaria or flu or COVID are diseases. And is depression a disease, or is it a state, such as fever? When I have high temperature, it's not a disease. I can die from it, but it's not really a disease, it's a state. And finally, when you have bipolar and monopolar, people don't know for sure whether it's the same condition or two different conditions, whether a patient diagnosed with depression can at some point develop a manic episode or not. So with these things in mind, let's maybe launch in. And these are some of the books that we will be referencing. The Brain and the Inner World is the oldest book written by Mark Solms. And Oliver Turnbull, a professor in Wales, edited it. It's a good textbook and a very good introductory text, but it's a little dated. The Feeling Brain is the second book. It's a collection of papers. And The Hidden Spring, Journey to the Source of Consciousness is the latest book. It is a very interesting read. It's a bit more advanced than The Brain and the Inner World, and it tackles the hard problem of consciousness, but it's very, very interesting read, and I highly recommend to anybody who's interested. If you are a clinician, particularly with background in neuropsychology and dynamic work with neurological patients, these two volumes are a bit more advanced. This is psychodynamic and psychoanalytic work with neurological patients, aphasia, vascular dementia, gunshot wounds. The first book has been written with Karen Kaplan-Solms, and the second book is a revisited version, which is the latest revision of the book. And of course, a lot of our work is based on affective neuroscience by Jaak Panksepp. He passed away in 2017, and we're very grateful for his work. As you know, there are major emotional classification systems in modern neuroscience. There is Paul Ekman with facial expressions. There's Jaak Panksepp with deep brain stimulation. There's Lisa Barrett and a few other theorists. If you are dealing with anxiety and fear, we can't, of course, ignore Joseph Ledoux. And we use a lot of work by Antonio Damasio on his work on the levels of consciousness. I've posted in the chat some links to our association. As I've mentioned, we're very democratic, and anybody's welcome to join if you would like. For me, it works great as a resource. I have to recertify my license every 2 years, and the materials that we have on our website I find to be, very high quality in terms of the low noise. And I really benefit in my clinical work from our training courses. And we have a specific learning platform called NPSA Learning, where you can actually learn directly from Jaak Panksepp. We have recorded videos while he was still alive. Christina Alberini, a prominent memory researcher, Mark Solms, another theorist. A little bit about people. So this gentleman with uneven hairstyle, I don't have any hair, but he's got a lot, and loose thigh is Mark Solms. He is a neuropsychologist from South Africa originally, who immigrated to London after he wrote his doctoral dissertation. And Mark worked at a Royal Hospital in the rehabilitation unit. He was doing neuropsychological assessment with neurological patients before surgery, after surgery. These are cases of TBI, vascular dementia, gunshot wounds. And in parallel, he studied in London Psychoanalytic Institute, one of the oldest institutes on the planet and very difficult to study in. And the joke is that Mark never told analysts that he was working with neurologists. He never told neurologists he's working with analysts. He kept it a secret. And the reason for that is that neurologists look down upon analysts and think that we're speculative and we're not connected to science. And analysts think that neurologists are too primitive, too biological, too concrete, and they cannot think flexibly. And Mark was feeling the gap in the 6 years of studies because he understands that mind doesn't float in the air. Mind is in, working with the brain. And we need both perspectives to help the patient best. So he created the field of neuropsychoanalysis. We had the first Congress, I believe, in 1999 in London. The journal was started, and this is how we came about. Jaak Panksepp is an American professor of Estonian origin who studied to be a psychotherapist originally and then changed his mind, thankfully, and became a scientist. And he worked a lot with mammals, with rats, and he developed an amazing body of work called affective neuroscience. And Maggie Zellner is a former editor-in-chief of our journal. She's a full analyst and a neuroscientist in New York City. A few other scientists, Christina Alberini at the top left corner is a leader of the lab in New York University, and she is a world-renowned expert in memory reconsolidation, something that is extremely valuable, I think, for all practicing therapists. She is also a full psychoanalyst and a prominent neuroscientist. A gentleman to the right from her, Nikolai Xmacher, is a professor in Bochum, Germany. He's leading a lab on memory research. And the most famous of all, perhaps, is a gentleman at the bottom right corner. His name is Carl Friston. You know that scientists, they have a Hirsch index, H index, and he's within top 20 of all scientists in the world presently. He's one of the 20 most famous scientists. If you know patients who have gone through MRI, then the statistics behind MRI were developed by Carl Friston. So he's the author of predictive coding framework, and he did a lot of many interesting works together. Carl Friston and Mark Solms are working right now on artificial intelligence, AI, that has emotions. All versions of AI up to now were emotionless. They're pure intellect, pure cognition, and they're working on creating an AI with emotions. And they have tackled the hard problem of consciousness. There's just a slide about Christine Alberini's work, Friston. So what is neuropsychoanalysis? What are we? Mark defines it as an interface or a bridge between all schools of psychoanalysis. We don't discriminate if you're Jungian or Lacanian or Kleinian, we don't care. All schools of psychoanalysis and all neurosciences. We would like to open the dialogue as opposed to not talking to each other. We'd like to learn from each other because analysts have a lot to learn from neurologists and vice versa. Neurologists have a lot to learn from analysts. And among this broad framework, broad bridge, we have multiple streams or lanes, if you wish. We have a clinical one, which is where I operate. I'm a clinician. It is about how to work with patients, better, if you wish. We have research field led by Alberini, Axmacher, and Solms. We have a philosophical framework where, we tackle the hard problem of consciousness formulated by David Chalmers. We do a lot of education. And all the way from introductory courses to a full certification that we have called Clinical Fellow of Neuropsychoanalysis. We have a social framework. We talk to each other. We're a community of clinicians who have common values, and we meet at congresses and seminars and other events. Now, because I've said we are a bridge, some people are saying, oh, I'm a child neuropsychoanalyst. I'm a family-based neuropsychoanalyst. We've had experiences where people read a book and they declare themselves a neuropsychoanalyst. That's not what we do. Mark is a very serious scientist, and if you're interested in about what neuropsychoanalysis is not, it is written very clearly in the book Feeling Brain, but we don't do armchair speculations. I have asked this question where if neuro is very cool right now. Everybody wants neuro. Everybody wants amygdala and prefrontal cortex and hippocampus, but that's not what we do. If you schlep amygdala to gestalt, you're not going to have a serious framework. We test our hypothesis in research. We conduct research, longitudinal studies, randomized clinical trials, and we verify everything in data. We're rooted in scientific approach. As opposed to just speculating about amygdala and saying amygdala is responsible for this or for that. We're also not a separate school of psychoanalysis. We do have Lacanians and Freudians and Kahusians, etc. As I've mentioned, we're neutral in terms of which framework you come from. But the important criterion, please be critical, please be skeptical. Important criterion is clinical work. If you find better outcomes in your clinical work from using our theories, then that's the ultimate judge. You can judge for yourself. So when is psychoanalysis and neuropsychoanalysis needed or not? Despite people who think that analysis and dynamic work is applicable for everything, we don't think so. For example, when the task is purely cognitive, the patient walks in the door and they can't sleep, they can't fall asleep. and you find out that they don't know basics about sleep hygiene, such that, the bedroom needs to be quiet, dark, and a little chilly, and don't look at the bright screen before you go to bed. So if you provide information and it helps and they start sleeping better, then you don't need psychoanalysis. You don't need dynamic work. That is a purely cognitive intervention. Sometimes the task is very narrow and behavioral, such as a specific phobia. Patient walks in the door and they say, I don't care about you talking about my mom and my dad, but I can't ride an elevator. I'm afraid of elevators. And then you hold them by the hand for 5 hours, and then for 2 hours, and then you repeat it a few times. The symptoms subside, not permanently, but there's some effect. And this is exposure therapy in CBT framework. You don't need psychoanalysis. There are also some conditions which are not mainstream conditions for what we do, such as schizophrenia. We know a history of very great dynamic clinicians, such as Frieda from Reichmann, who worked not far from me in Chestnut Lodge Hospital here in Maryland. But, there's history of dynamic clinicians working with schizophrenia patients, but we don't claim to do anything differently. And autism spectrum disorder, we have new models, integrative models, but this is not necessarily what Mark works on. He works primarily with adults. Acute trauma is a little bit different. It is a very interesting work that I specialize in. And again, Mark's theory is about more neurotic cases than acute trauma cases. Couples, families, not necessarily what we do. And finally, if you have a neurological patient who have severe level of impairment, such as a receptive aphasia, Wernicke aphasia, we don't think it's possible to work with them in psychoanalysis or dynamic therapy. With Broca's aphasia, we can work. Wernicke, not so much. So when is psychoanalysis and neuropsychoanalysis appropriate? It is more appropriate when there's evidence, there's data that unconscious is at play in what's going on. For example, the patient says that, I know exactly why I shouldn't be doing this in relationships, but I'm doing it anyway, okay? Or they are saying, I have a feeling it's unpleasant and it's been haunting me for a long time, and I don't know what's it about and how it came about, but that's what I have. There's sort of a feeling detached from context, right? There is an explanatory gap. Usually that suggests that unconscious dynamics are at play, and this is where we are applicable good fit. Any presenting problem suitable for classical psychoanalysis is suitable for neuropsychoanalysis. And we work with neurological conditions, which is new. Prior to Mark, please note, analysts were afraid of neurological patients. If somebody has vascular dementia, nobody would offer them therapy, and they do need therapy. They suffer greatly. And we have shown many cases of specific neurological conditions where we can help patients in psychotherapy. What we are doing now is something that Freud predicted would happen. Let me cite Freud and give you a couple of quotes. Freud said, we must recollect that all our provisional ideas in psychology will presumably someday be based on organic substructure. And then he said, the theoretical structure of psychoanalysis is in truth a superstructure, which will be one day set on its organic foundation. I'll spare you the larger quotation, but essentially, Freud was definitely not against the brain. He was a prominent neurologist. As you know, he had published works on aphasia. He was so good as a neurologist that American students lined up so he could teach them to diagnose the pathology based on symptoms. And the pathologist who examined the patient after the patient would die would say, Professor Freud was right. So he was a very good neurologist, but he abandoned neurology because neurology wasn't up to speed with what Freud developed. Neurology of the time in Germany, led by Professor Theodor Meinert, was static. They had these diagrams with, blocks and arrows, and they said, this part of the brain is responsible for that, which is a static approach. Freud did not want to work this way. He was a dynamic theorist, which is very important, and we'll show some evidence about why. But essentially, Freud knew that what he created in psychoanalysis was, as he called it, provisional or temporary. Those who like to create an icon from Freud, put him up on the wall and dust it and say, don't touch Freud, this is pure knowledge. They don't know that he was a scientist. He was okay with updating his models and theories based on data, based on new information. And so we are proceeding. We're not replacing Freud. We're, with great respect, following in his footsteps and continuing his work. And as I've mentioned, Mark is a prominent Freudian. He translated the entire volume of work by Freud from German into English again. He's the official translator of the full volume of Freud. Why? Why do we do this? We do this to verify, confirm, or update psychoanalytic models and hypotheses using the tools of modern neuroscience, because it is necessary. We try to integrate top-down and bottom-up models of mental disorders, as I've illustrated before with stalactites and stalagmites. We try to integrate subjective and objective data sources. And let me just clearly articulate what I mean by these terms. Subjective is something I feel from within, and objective is something that you can observe outside of my head, outside of my skull. If you remember a wonderful book by Oliver Sacks, The Man Who Mistook His Wife for a Hat, Oliver was on his way to see the patient in the patient's home. He did house calls and he stopped at a flower shop. This is how he rolled. And he diagnosed visual agnosia based on the rose in his lapel. So if I'm smelling the rose, my Alexey's feeling about the rose are subjective, how I perceive the rose. But if you put me with this rose in the fMRI machine and you observe the state of my neuronal network, this will be objective data of my perceptions. And we need both. We shouldn't throw away half of this data. We need both. We do sometimes find neuroanatomic correlates of psychoanalytic constructs. We develop new and update existing methods of working in dynamic therapy, which is technique. And we have developed a system of working with neurological patients. A few quick examples. To the right, you see a picture from Freud. This is a picture of his structural model with id, ego, and superego, and repression barrier and all of this good stuff. And in his book, The Brain and the Inner World, Mark makes a very strong point that ventral medial prefrontal cortex, the area of the brain highlighted in red, if you write down all ego functions by Freud, then you will see that ventral medial prefrontal cortex is essential in fulfilling this function. When that part of the brain is damaged, you will not be able to proceed in analysis. The clinical case is Phineas Gage, a railway worker who had an iron rod go through his brain. That's the part of the brain that was damaged, and his personality changed a great deal. We're not saying that there's analogous, that VMPFC is exactly the ego, but without VMPFC, ego functions are not possible. And now Mark would probably update it to dorsolateral PFC and other areas of the brain. In Freud, id is mostly unconscious. This has changed, and Mark has a 3-hour lecture and a lot of papers. And if you're interested, I'll send you links to them. They're publicly available about the conscious id. We are departing from Descartes a long time ago, and we're talking about feelings a lot. And we don't have time here and now to talk about why Mark thinks id is conscious. In fact, the core of consciousness, but in our framework, id is conscious. Some other data. In the interpretation of dreams, Freud wrote that wish, I want, and wish fulfillment were prominent components of dream content. We have a huge body of work in neuroscientific literature to support this statement. The system called seeking that I'll be talking about later, the I want system, lights up like a Christmas tree during dreams. Something that Freud called infantile amnesia, which is a phenomenon that young children, 6-month-old children, do not remember what happened to them. They do not remember episodes of their life, and that is not related to language. Is well known, and we see it scientifically. Now, Freud had a hypothesis of why that is. He thought the reason for that was repression. And Christine Alberini in her lab studied formally infantile amnesia with mammals. And she, of course, sees the phenomenon. We do see it happening, but the reason why is not correct. She found out that Freudian hypothesis of repression was not accurate, nor is the alternative developmental hypothesis that hippocampus is not mature enough to lay down episodic memories. And she came up with an alternative hypothesis that there's a sensitive period of development of hippocampus where children learn to learn. And it's a very interesting framework that if you're interested, we can talk about. Repressed material in Freud returns, and part of the work and analysis is to, where id was, the ego shall be. In our framework, we show that repressed can never return, actually. In acute trauma, I'm talking about acute PTSD, some analysts think that the episode of trauma, the autobiographical episode of what happened, is somewhere there in the depths of the unconscious, repressed, because it's very painful. Now, what happens is that hippocampus is actually flooded by cortisol in acute trauma, and the episodic memory is not laid down. It is simply not there. It is not repressed. It is not there. And therefore, when we work in analysis or dynamic therapy, we reconstruct something. The patient has shards of glass. He has pieces of procedural memories, semantic memories, but not an episode, and we construct an episode. That's a deviation. That's a change, essentially. The second set of reasons is to take a stand in the philosophical dilemma of brain-mind. There's an easy and the hard problem of consciousness. And Solms is a dual aspect monist. For those of you, I'm not a big philosopher, bear with me, but so in Descartes, the mental and the physical are completely different things, not reducible to one another. That's dualism, very prominent in Christianity. In monism, which is the school of Baruch Spinoza, there is something called brain-mind. They are one and the same. And if you perceive it from the inside subjectively, we'll call it the mind. And if you perceive it from the outside, we'll call it the brain. But they're not correlates. They're not two different things. They're one and the same. An example is Mark Solms wakes up in the morning and he feels like Mark Solms. He opens his eyes. He realizes that he is Mark Solms. That is subjective. And then he looks in the mirror and he sees an image of his face and his body. And that is objective. But these are not two different things. They're not two different Mark Solms. It is the same Mark Solms, but he perceives it subjectively or objectively. Again, I'm not trying to sell it to you. This is a complex philosophical question, and you can read a very detailed paper by Solms called The Hard Problem of Consciousness and Free Energy Principle if you want. But he, being a very expert Freudian, thinks that Freud was a dual aspect monist as we think affects our work in analysis and in dynamic therapy with patients. It may seem trivial to you, but it's not. Specifically, it has to do with knowledge base. For example, I had a sign that my internet connection is unstable. Can you all hear me and see me?
No, it was just a short moment that you were disconnected, but now we can hear.
You can hear, okay. Is everybody else here? Is everything okay?
Yes.
Let me see. Yes, okay. So if, for example, patient walks in the door and they say that they suffer from symptoms of depression. If a clinical psychologist does not know that thyroid dysfunction can be responsible for the symptoms, they wouldn't even ask this question. And they could shoot blank. They could be doing something different from what needs to be done when the patient has Hashimoto disease or Graves' disease. This is knowledge that would affect clinical work. If people have stereotypes, biases, racism, sexism that will affect their work, whether people are thinking just in categories or just in spectrum will affect how they work. Personal therapy, we usually tell students that they have to go to personal therapy, but we don't really explain why. And the reason why is that we don't work with a scalpel or a stethoscope. Our mind is the main instrument that we use in therapy. And if you want to be a master clinician, then you have to know your instrument and you have to know how to operate it. And finally, the complexity of how we model things is important. If, for example, you're studying the movement of spaceships, then if you're in vacuum, like James Webb Telescope, you can model James Webb Telescope as a sphere or a cube. You don't need any more complexity. But if it were to enter atmosphere, you would need to increase the complexity in your model to account for aerodynamics. And the important thing is all theories we have been using up until now in psychoanalysis, Freudian theories, Kleinian theories, are models. They're not facts. And I wish somebody told me that when I was a student. Because when people repeat to you projective identification 7 times, you tend to think about it as fact. It is not a fact, it is a model. And when you model things, you need to make sure that the model's complexity level is approximately the same as the phenomenon you're studying. I will try to show you a brief video, and Giga will correct me if this is not working. Let me see, no share. Giga, can everybody see the screen right now with a brain?
We can only see the link.
You cannot see the link? Okay, hold on a second.
No, we see link and
you see the
video.
Let me try one more time. Okay.
Yes,
Can you,
here it is, here it is.
Let's look at the video for a few seconds. So what you're looking at is the fish brain, about 100,000 neurons, okay? Human brain is much more complex than that. Human brain is 86 billion neurons with a prominent neocortex. But this, my dear colleagues, is the object that we work with, okay? All right, and the mind is not any less complex than that. You can clearly see that this is dynamic. The static models are no longer applicable. This is dynamic, right? Let me go back to the presentation. Hold on a second. I'm stopping sharing. I'm returning back to my presentation. Can you see the slides? Hello?
The link again.
The link again. Hold on a second. Stop sharing. Share screen. Can you see the slides?
Yes, yes,
Okay,
yes,
right.
yes.
So what I'll do now may rub some of you the wrong way. I will try to look at classical analytic theories from the standpoint of mathematics. What was that? Hello?
Yes, one of our participants are not muted, is not.
მიკროფონი გამოვთოთ თუ შეიძლება მიკროფონი.
Now she is. Now she...
Okay. All right. So you see our beloved Melanie Klein, who contributed to our field a lot, and her work is very clinically useful and very complex, very sophisticated. But again, bear with me, I'm going to do blasphemous, heretical thing. From the standpoint of mathematics, Melanie Klein suggested that mental states of the patient can be either paranoid, schizoid, or depressive positions. Just two options, two buckets. One of her followers, Thomas Ogden, who's now in San Francisco, developed a third option, autistic contiguous position. From the standpoint of mathematics, you're classifying the infinite variety of mental states of the patient into two buckets or three buckets with Ogden. That mathematically is three fixed points in space. This is basic geometry level, basic Euclidean geometry. If any of you study Rorschach, below is the previous version by John Exner Jr., comprehensive system, not the RPAS. This is the formula for the mental resources of a human being, plus minus multiplied by 1.5. This is the level of basic algebra. This is the mathematics we use in dynamic theories, because Rorschach is deeply psychodynamic. If you study Freudian theory of conflict or Charles Brenner theory of conflict, then I put it out there, then vector algebra is entirely sufficient to describe what he says. You do not need differential equations or topology or probability. By comparison, if you look at neuroscience, this is how they study a synapse, the elementary unit of the neuronal network. You immediately see differential equations, and it's much more sophisticated. So what I'm trying to say is there is a gap in complexity. We have been grossly oversimplifying the object that we study by the models that we use, okay? And Mark Solms and Carl Friston, this is a macro model in the brain, have changed some of that, and they are using these differential equations. They use Markov blankets, they use tools from stochastic and statistical mechanics. And so mathematics became much more complex. And then there's a hierarchy, embedded hierarchy of predictive coding. So we are correcting that because we have been operating with mathematically, I want to highlight that, not analytically, but mathematically, very simple models. The fourth reason why we do this is there is issue of Babylon in psychoanalysis. I'm going to quote to you two prominent theorists. One is Frederick Bush. He's a prominent ego psychologist, aka Freudian. This paper is called Oedipal Dynamics and Panic Disorder. Bear with me if you're not analysts. This is what he says. The ego weakness, typical defenses, and pre-Oedipal dynamics described above intensify the subsequent danger of Oedipal longings in a panic patient. Thus, aggressive strivings of the positive Oedipus complex and dependent and homosexual fantasies of the negative Oedipal complex seem more dangerous, and castration anxiety, seen in an extreme sense of body vulnerability and death fears, further fuels the separation anxiety activated earlier, okay? This is a text about panic. And I'm quoting Betty Joseph, who's a prominent Kleinian analyst. She says, I'm assuming that this type of projective identification is deeply unconscious and not verbalized. If we work only with a part that is verbalized, we do not really take into account the object relationships being acted out in the transference. Here, for example, the relationship between the uncomprehending mother and the infant who feels unable to be understood, and it is this that forms the bedrock of her personality. Okay, I'm not saying that these are senseless texts. They are very meaningful and very difficult if you operate in this language, if you are fluent in the language of ego theory or object relations. But they're two different languages. They're Chinese and Hungarian, okay? And a prominent American analyst, Jonathan Shedler, says the following about it. Just look at the difference between how we study and talk about psychoanalysis versus any other academic or scholarly discipline. There are no university departments of Darwin. There are university departments of evolutionary biology. Yet the study of psychoanalysis is often organized around the names of theorists. People don't say, right now I'm studying this idea. They say, I'm studying Winnicott or Klein or Kohut. Instead of emphasizing the shared corpus of knowledge and ideas, we sometimes sound like competing personality cults. That's a valid criticism from within. He's not a cognitive behavioral. He's a very prominent and fully licensed analyst and a researcher. And I'd like to spend some time on this slide. This is the slide of memory classification systems that Mark allowed me to use. This is from his presentation. I'm trying to map a little bit Freudian concepts on modern neuropsychology. So the cloud you see at top is short-term memory, or we also call it working memory. This is the buffer, the space in mind where we think. If you tell me, Alexey, you have 3 apples, I gave you 2 more, how many you have total? So the place where I have 3, 2, and then I do the summation, I have 5, that space is called working memory or short-term memory. By the Miller's law, it's about 7 units of information plus minus 2. I have, when I've tested individuals with Alzheimer's, they had about 5. Musicians have about 9. But anyway, it's a very small, very narrow place. If you like computer science, then you can probably call it RAM, random access memory. Unlike computers, our random access memory is very small. Now, I think things as I go through the day, and those of them that are important get written down for later, and that's called long-term memory. The process of laying down long-term memory is called encoding, okay? And hippocampus is primarily involved in that. It's a structure in the temporal lobe. Long-term memory can be of 2 different kinds, declarative or explicit and non-declarative or implicit. Declarative memory, by definition, is something that I can reopen into short-term memory. I can think it. I can, return it back. And non-declarative memory is something that cannot be thought again. There are 2 different kinds of declarative memories, episodic and semantic memories. Episodes are just that. They're episodes of my life, autobiographical episodes, such as my 7th birthday, there was a cake and the sun was shining, and I was in a good mood, is an episode of life. And we lay those down every day, every moment of our being. Semantic memory is a bit of a generalization from episodes. For example, I'll use so when a child is looking at a raven, then he sees a black something that flies. And when a child is looking at the canary, he sees a yellow something that flies. And they're 2 different things in a very young child. And eventually, as they learn, they realize that there's something in common, that there's the beak and the wings and the thing flies, and they come up with an object called bird. Bird is a category, and bird is an abstraction. It's a higher level of abstraction than canary or raven, and it is a semantic memory. Or Mark's example, if I have a new job, say I teach at a university, and on Monday I get in my car and I drive to work, and I drive 1 kilometer straight, then I make a left turn, then there's a stop sign, I make a U-turn, etc. So on Monday, I'll lay down a movie of how I go about getting to work, okay? On Tuesday, I have another movie of exactly the same, and it's a little different. It's another episode of my life. On Wednesday, I have a 3rd movie, and as you can see, it's very inefficient. By Thursday or Friday, I will develop something crystallized from these episodes called route, something general, straight, left, stop sign, U-turn, okay? As I keep on driving to work, I will develop a habit, which is a procedural memory, and I'll stop thinking. I will automatically get to work, and my mind will be free to do other things, to think about whatever. And that is a procedural memory. Now, on the right of the slide, you see something called non-declarative, and Freud would call it unconscious. Unconscious is something that cannot be thought about. Preconscious, on the other side, is something that you can think. So one example of unconscious is procedural memory that I just said. The easiest example is motor procedural memory, such as walking. When I walk and get up from this chair, how the quad muscle of my leg moves is not something I can think about. It's completely unconscious, not preconscious, fully unconscious. And by the way, a lot of emotional things are also entirely unconscious, and they are procedural memories, they're habits. They're hard to learn and hard to forget. One more type of non-declarative memory that I'll mention is called an emotional memory, and that is mediated by amygdala. For example, a phobia. If you have a child that by accident put 2 fingers in the power outlet and they had a shock, this is one-time exposure and lifelong memory, very stable memory, a phobic memory. Again, he cannot think it through. It's very raw. It's sort of stimulus reaction, right? And these memories are unconscious. Our clinical model is based on Freud's structural theory with an addition of affective neuroscience by Jaak Panksepp. So id has been expanded from 2 drives to 7 drives by Panksepp, and id became conscious. We preserved the primary and secondary processes by Freud. We actively use memory consolidation, reconsolidation constructs, and it is a living model that we continue to update based on data to go back into consolidation, reconsolidation. So again, if I am thinking something right now and I lay down a long-term memory, this is consolidation of memory, right? And a lot of memories get consolidated as we sleep. If I recall something and it gets from long-term memory back into my short-term memory, the memory becomes labile again, and then I put it back down. That's a reconsolidation. These mechanisms are extremely valuable for therapy. A lot of what we do in psychotherapy is actually memory reconsolidation. So knowing how that works is essential for therapists, I think. Okay. So to say a little bit about psychiatry, I interact with psychiatrists and collaborate, and I admire them and respect them. However, we think that psychiatric treatment of distress is a symptomatic treatment. Example is, say, a flu, right? You have a flu. Flu is a viral infection, right? And you have fever, you have high temperature, and so you take paracetamol or Tylenol. Your fever goes down, your temperature goes down. You treat the symptom, but it does nothing to the virus, absolutely nothing, right? So it is not a causal treatment. You treat the symptom. We think that all of psychiatry is like that. If you have a panic episode right now, you take Klonopin or Xanax, panic goes down, but it does nothing to the cause of the panic, etc. Antipsychotic drugs, they relieve you from hallucination right now, but they do nothing to the cause. What we try to do is we try to say that symptoms mean something. Now, this is not mysticism or magical thinking. In medicine, symptoms mean something. If I have an acute pain in my leg, that means I have a laceration, I have a wound. If I'm fatigued, that means my body needs rest. Fever means inflammation. There's something behind the symptom. There's a reason and a cause, okay? And when patients walk in the door for psychotherapy, they are suffering from some kind of emotional distress. And our first order of business is try to understand what exactly they're suffering from, okay? What kind of emotional pain do they have? Then we try to find out how it came about. What habits and what adaptations and defenses they formed early in childhood or later in childhood or in adolescence, that this issue continues to happen. Behind this feeling, there's usually a need that is unmet, chronically unmet. And thus there's an imbalance in their emotional functioning. And this imbalance became habitual. It became a procedural memory. And some of the solutions that children developed in childhood became these habits. To give you an example, to go back a moment to the slide of memory, in Maison Verte, you work a lot with children. Perhaps some of these children have experienced divorce of their parents or separation. And what we see often in clinical practice is, at times, children react to the divorce of the parents by developing guilt, by saying it's my fault, right? And it doesn't make any sense. It's not a rational adaptation, right? But what happens there, if we drill down, is maybe child is very angry at father, for example, or at mother for wishing to go away and break the family. But they're terrified to express their anger to the parent because of separation distress. Separation anxiety is very prominent and very strong in children. It is much more dangerous to lose a parent than to face some other stressors. So there's a mental conflict, a wish to express anger versus the fear of loss. And they cannot resolve this conflict with their 7 bits of information. They can't solve that issue. And they come up with a solution that does not work, such as return their anger inward and turn it into guilt and say, my fault, which is a self-directed aggression, right? That is not a working solution, but it is the best they can do. And then they repeat it and repeat it and repeat it, and it becomes a procedural memory. It becomes the memory that is fully unconscious. It becomes a habit like walking and talking. And then you have an adult patient prone for guilt in your psychotherapy environment. But that material, when it's repressed into the procedural memory, it can never return back. You cannot think about it. You know, the actual habit of drawing toward guilt in this circumstance is procedural. So in that sense, repressed never returns. Procedural memories cannot be thought about. Let's say briefly about affective neuroscience. And the starting point is that, you know, how different from all the other mammals is we have a very prominent neocortex, right? But if you remove that part, if you remove the layer on top of the brain in mammals, then the emotional systems are all preserved, the basic emotional command systems. In fact, animal becomes more emotional. I mean, there's studies with decorticated cats. And Jaak Panksepp studied these systems, and he came up with 7 basic systems called seeking, lust, rage, fear, panic, care, and play that are a 3-tier hierarchy. Each one of them is complex, and we'll talk briefly about maybe just 2 of them. They all have projections into periaqueductal gray, and I'll spare you the chemistry and the neuroanatomy. And the 3-tier hierarchy is this, that we have something inborn. Let's take a mouse, for example, or a rat. Mice have a fear of cats from birth. If you take a rat pup, just born, no learning, mom didn't teach it anything, and you put 1 strand of cat hair into the cage, the cat freezes. Okay, inborn phobia of cats. This is the basic low-level inborn phobia, right, from birth. Now, if the mouse lives in a house with humans, it may develop a fear of human odor because humans are dangerous. And this is something they learn at the level of basal ganglia. This is the secondary process. This is upper limbic structure. Now, later on, they run around the house and they see that their brother got into the mousetrap where there was peanut butter or cheese, right? And this is the cortical level of learning because the mouse is drawn toward food. It wants to approach the food, but it sees that his brother got in trouble. And that's learning from experience. This is ego. And that's the 3rd level of the hierarchy. And so it is both bottom up and top down, and it's highly complex within each of those systems of how the learning happens. But I gave you a brief example of the mouse in a human house learning what to be afraid of, what not to be afraid of, and how that particular system, fear, is trained through development. So seeking is the largest positive motivational system. It used to be called reward system by people who discovered it, Olds and Milner, and that's a very unfortunate name for it. Seeking is an appetitive system. It is I want, not I like this, right? It is drawn toward. It's the enthusiasm, it's the expectation, it's the hope of getting a positive stimulus, not the pleasure. Eating chocolate is not that system. Wanting chocolate is that system. It's dopaminergic. Why do we need it? Because all the resources we need for survival are outside of our body. Food, water, sexual objects. And all the needs are inside the body. And in order for me to survive, I need to go out in the world and find the resources. If I'm a hunter-gatherer who woke up in the morning, there's no food, there's no fridge, right? So I need to go in the field and forage mushrooms or berries or kill the boar and bring it home. This is the hunting, the expectation is the seeking system. It is objectless. It is I want, not I want an apple. Babies from birth don't know what apple is. And when they see an apple, they don't react. But once they learn through experience that apple is edible, which is a semantic memory, then when they perceive the apple, they will be drawn toward it. So if we break it down a little bit, so the seeking system is surrounded by need detector on the one side, which is hypothalamus, and the memory systems on the other side. So let's say the blood sugar drops and the baby is hungry. Baby wants to eat. This activates the seeking system saying, I want to find food. And then they look around and they see an apple. If they've learned previously, they have a memory that apple is edible, then they're drawn toward it. They have a motor action of taking an apple and biting into it, and then they fulfill the drive, right? It's dopaminergic system, ventral tegmental area, nucleus accumbens, dorsolateral hypothalamus, anterior cingulate cortex. The moderate activation is enthusiasm, and the top level of activation is euphoria. If you work with manic patients who have cocaine addiction, then you know the system very well. This is the graphical anatomical explanation. It's mesocortical mesolimbic dopaminergic system. I'll talk about just one more, and we don't have time for the rest. Panic system is the system of separation distress. Okay? There's two different kinds of anxiety, as analysts knew for a long time. There is depressive anxiety, and then there's paranoid anxiety, fear and depression. So this is depressive anxiety in psychoanalytic terms. We also have seen empirically that panic disorder, depression, and separation anxiety somehow are very close. Somehow we see them together all the time. And analysts did not know why that is. And this is why, because it is the same system in the brain called panic. This is separation distress system. Those of you who are parents have seen your baby in a crib when mom leaves the room. What baby does? Baby is upset, baby yells, ah! Baby is actually angry in that moment. This is what John Bowlby called protest. Baby demands that mom comes back. Baby's enraged, ah, right? So if that works and mom comes back, then there's soothing and hug and whatever, right? But if mom doesn't come back for whatever reason, say mom is preoccupied elsewhere, arguing with dad, depressed or something like that, and eventually baby stops crying because it's upsetting, baby crawls in the fetal position, sucks the thumb, and looks sad. The seeking system, the I want system, is turned off. And the reason for that is a mammal, say baby, I don't know, deer, if mom is out, should not wander away from the cave, should not be curious, because then it will be killed by wolves. It needs to stay put. So the enthusiasm is turned off and baby is sad. Statistically, the probability of survival for that baby is higher in this mode. So I just described how the panic, the separation from the caregiver, activates the depressive dynamics. But what the outcome is of that is that the seeking system is turned off. We don't want anything, right? So the system of separation distress is oxytocin and prolactin. The core is anterior cingulate cortex. As you know, it's one of the areas of the brain that processes pain. So the mental pain of separation and loss is not that much different at that level of the hierarchy as the physical pain. If you stimulate that part of the brain with the electrode, the patient will have a panic attack. You can induce a suicidal depression in substantia nigra. You can induce panic by electrically stimulating that part of the brain. So, and these are very interesting examples if you're interested in surgery where, you know, within minutes, you know, patient becomes suicidally depressed. You withdraw stimulation, they stop being depressed. You put it back, they start being depressed. And separation from loved ones activates panic. So I'll spare you their other systems. By the way, Freud did not know the difference between lust, which is sexual drive, and seeking, which is I want system. He called them both libido, and we separate the two. Clinical observation. So all these things I've mentioned before about depression and mania and hypomania and panic, we can see now that take one system, which is seeking, and you put it in overdrive, which is I want everything. Have you seen people on cocaine? They want this, that, and the other. They spend all the money. They talk fast. They think fast. You know, they want to have sex with everything that moves. This is seeking system in overdrive, okay? And it's a state. You can get into that state 7 different ways: sleep deprivation, drugs, medication, etc., etc. And when that system is shut, when I want nothing, I'm in bed, face to the wall. I don't want sex. I don't want entertainment, food, water. It's depression. And it's the state of, you know, low functioning seeking system that, again, you can get into different ways: electrical stimulation, chemical, mental loss, divorce, immigration, being fired from the job. So we don't think depression is a disease, we think it's a state, okay? And normal biological activation of depression, which could be an adaptive response, is separation. We'll go back to Freud's paper, Mourning and Melancholy, where the loss, originally of the caregiver, but in adulthood, it could be the loss of your job or reputation or elsewhere, is triggering the depression. I can say a lot more, but maybe I should move on. Giga, how we're doing? Should I go into the case or should we stop here for discussion? I don't mind one way or another.
Да, можно, что перейти на кейс. Почему бы нет?
Хорошо.
It would be very interesting.
Sure. I don't think you may see much new, but maybe a different way of looking at things. So this is an 83-year-old lady. I will call her Paula. all the names and all the identifying details have changed. She's retired and an immigrant from Portugal. Now I work in Maryland, United States. She's a middle child. She had an older and younger brothers, and her father died very young when she was 5 years old. She survived World War II and saw many hardships. She saw famine and a lot of death. At about age 20, she immigrated to the United States. And as you know, immigration is a huge stress. She got married, and adaptation to living in the States was very hard. A lot of low-paying jobs, studied English at night. She divorced her husband about 15 years into marriage. Was very bloody, very painful divorce. They fought over children. She subsequently married a second time, had another child, and there's 3 grandchildren when I met her. And when we started working together, she learned that her first husband has died recently, which unexpectedly affected her very strongly. And her brother in Portugal, her younger brother, is about to die from terminal cancer. These are just some biographical details. Now, when she talks about her life, then I understand that her relationship with her husband and children is very kind of distant and cold, not very warm and nurturing. She does love her grandson. Actually, I'm not sure if it's actually love. She brags about her grandson. She talks that he is like an expert in Portuguese, but I don't really think that she perceives him as a human being. She was referred to me by her neurologist, who suspected pseudo-dementia, which many of you know is depression that at the symptom level seems like dementia, because depression affects cognitive functioning very strongly. He prescribed her antidepressants that didn't have any effect, so he referred her to me. The MRI showed moderate atrophy in the temporal lobes bilaterally, more on the left. And again, atrophy is not analogous to dementia by any measure. She had significant hearing issues. She had Meniere's disease, and she was deaf on one side and used hearing aids. She couldn't sleep. She had insomnia and depression and social issues. So there's a lot going on, and patient is 83 years old. I happened to did a neuropsychological evaluation with her. And one of the tests that we do there is word learning, where you give her 10 words, you repeat them slowly, and she repeats them after you. Then you do it again and again and again. So there's 4 repetitions. And healthy individuals learn. They go from 4 words to 5 to 6 to 9, whatever. She stopped learning at about 5. It was a flat curve. She couldn't acquire more learning. So there's issues with memory. She's issues with learning. Then we usually distract the patients by doing other things for about 15 minutes or so. And we ask her to tell us the 10 words. In free recall, she could repeat only 1, which suggests a memory problem. Not a proof, but suggests that there's a memory problem. But then we don't stop at that. I give her a second task called recognition. I said, was it an apple or an orange? Was it a school or a church? And she recognized 100%. Now, what that tells me is that the issue is not encoding of the memory. The issue is retrieval, okay? Because when encoding is a problem, recognition doesn't work. When patients with Alzheimer's, it's chance. They cannot do recognition because the memory is simply not there, right? So that's my working hypothesis, that audio-verbal encoding is intact, but impairment in retrieval is present. In terms of visual spatial memory, she had moderate impairment. She had dysnomia, which is ability to name things. I show her this, and I said, what is that? And she goes, oh, you do this with that. I said, what's it called? And she couldn't say, it's a pen, right? Which happens sometimes, and individuals have amnesia, and she had intact functioning in other areas. The difficulty is that when she drove to my office, she got lost, and she called me on the phone. I had to walk out and meet her and guide her to my office. That happened twice. When she talked to me, she repeated herself a few times, and she was very oriented to treating me as a memory doctor. She thought that I would cure her memory issues by giving her some strategies like eat blueberries or exercise or something like that. And because she couldn't hear well, had a hearing impairment, she had to sit very close to me, which affects the dynamic relationships. The patient is not far away from you on the couch. The patient is nearly in your face, right? In terms of transference, I felt a little bit as a son, a little bit as a doctor. And she had a fantasy that I'm like a caring son who would cure her of the disease, right? Of course, these are speculations. I don't know for sure how she perceived it, but that's how it felt, that I was sort of a doctor's son. At times, I sensed that she devalued objects, such as, with me, it was compensated. She didn't really devalue me all that much, sometimes, but she devalued her husband by calling him an idiot, and children by being knuckleheads and not good enough, and all other doctors were idiots who didn't know what they were doing, right? In countertransference, I felt helpless. I felt like, Alexey, what are you doing? This is probably dementia. This is, you can't work with this patient, right? And I also felt anger and annoyance because she pulled me to do something that isn't my job, to cure her memory, right? The question on the table is this. So she wrote a book of children's stories and stopped and didn't publish it. Various excuses she gave me, such as like, I need to edit it again, and it's no good. I need to revisit chapter 9, and I can't find the publisher. She's 83 years old, needed to do a will for her children, and she would stop and not do her will. She didn't do it. Also, because of her significant hearing loss, there's an operation in the States called cochlear implant operation that is expensive. It's $100,000, but it was covered by insurance for her. And she could do it, which would restore hearing, and that would help her with social life, but she stopped and was reluctant to do it. So the question is, why? Why wouldn't she do it? My hypothesis was, there's nothing earth-shattering or mind-blowing here, is that these things, the book, the will, the reluctance to do the operation, were like her last shield from death. That if she were to cross that boundary, that the death would come. So she was holding on to the straw, right? And that's the hypothesis. In terms of our question in neuropsychoanalysis, what hurts? What is the emotional pain? I thought that it was the fear of loss, not the fear of death, but the fear of loss, because she was afraid to lose her mind, to lose her hearing, to lose sleep, to lose memory, to lose friends, not of death. In fact, she explicitly said that and was at times suicidal. She said, I don't mind death, but I don't want to be a vegetable. I don't want to lose my mind. Okay? In terms of defenses, I think that she was in the borderline, or Mark called it narcissistic level of functioning. So there was prominent splitting. She introjected an omnipotent, godlike object, and she projected weakness and helplessness onto me. There was a fantasy or compromise formation of this last shield that would protect her from death. Fantasy of immortality, again, a grandiose, omnipotent fantasy. She had difficulty accepting the losses and grieving and crying. In therapy, because she's narcissistically oriented, I took my sweet time building therapeutic alliance. Because as you know, nothing gets done until alliance is strong. And with narcissistic patients, you need to be very careful because they're prone to flipping into narcissistic range after a narcissistic injury. So I avoided all interpretations initially while I built the alliance. And I focused on telling her one thing. I said, Paula, I think that what hurts for you is you wish to be cared for, which is a need behind the panic system. And that resonated. She could hear that, and she haven't heard that said as clearly ever before. There was a lot of empathy and support. And I used McWilliams' advice of strike the iron when it's cold, because with narcissistic patients, you don't do an intervention when they're hot, they're going to flee. When the alliance was established, I carefully allowed myself to test my hypothesis by an interpretation, and I told her what I thought about the book and the will. And she had a strong emotional resonance. She didn't cry, but I could see that she reacted to that emotionally, not cognitively. She did not forget that intervention despite her memory challenges. She was surprised. And she maintained that insight in subsequent sessions. In addition, of course, we did transference work, and I worked on her projective identification of helplessness with me. It took about a year, and it was up and down. It was not a smooth progress, and she regressed sometimes in deeper depression, and she had back pain and other things. But after about a year of work, she continued working on publishing the book. She wrote her will. And importantly, she scheduled the operation of cochlear implant and did it, and successfully. It took about a month for her to adapt, but she could hear. Her hearing was restored. And because of that, she went back to her poker club and her social life improved. All of these things combined made her feel better. Again, I don't claim that, this was directly as a result of our work together, but this is kind of what happened in her life. She also became softer. She wasn't as kind of rigid and sitting on a high horse. We stopped during pandemic because she refused to work remotely on a computer. She wanted to see me in person, in part because of, habit. And she called me several times demanding, did you open your office back up? And I said, no, I didn't. And, she was upset, but we did not resume. And that's it. And if you want, we can go into questions and answers.
Thank you very much.
Спасибо большое, Алексей, было очень интересно. Ითხოვებით თუ გვაქვს, შეგვიძლია დავსვათ ინგლისურად ან ქართულად და მე ვეცებ ვთარგმნო თქვათ რუსულად ან ჩვენმა კოლეგებმა ინგლისურად თარგმნონ. მოკლედ სამი ენა გვაქვს სამუშაო და გავარჩათ.
Would you like a little break? Is everybody tired? You want to take a minute or two, or you want to continue?
You want a break?
No, I'm fine. I'm okay.
You
But
are
if
fine.
you,
Okay.
yeah.
For me, it's okay what others will say.
So you can ask me in English or in Russian. I don't speak German.
Алексей,
Georgian.
я слышал вашу лекцию и по-русски тоже, и по-английски сейчас большую часть понял, и коллега еще помог. Я хотел бы вам спросить, что вы имели в виду более конкретно, когда вы сказали, что нет возвращения вытесненного? Потому что, если честно, вся теория Фрейда об образовании психоневротического симптома базируется на том, что вытесненное, оно возвращается. Может быть, не в той форме, в которой она была вытеснена, но она возвращается метафорично, она возвращается в сновидениях, она возвращается на уровне поведения, которую постоянно детерминирует вытесненное. А иногда возвращается с такой силой, потому что всегда инвестировано в лечение ТРИБ, что субъект вынужден создать психоневротический симптом как компромисс, то есть как защита. И если нет возвращения вытесненного, тогда зачем симптом? То есть это все переворачивает, это очень важно.
Да, конечно. Giga, should I answer in Russian or in English?
Если по-английски, тогда придется что переводить. Ну, все-таки придется переводить в любом случае. Может быть, по-русски и кто-то переводит.
Хорошо. Давайте я отвечу по-русски.
Я уже пойму ответ оригинальный. Прямо из ваших уст.
Ну, Гига, тема сложная, она не очень простая. Я бы вас пригласил пока заметить, что все, что сделал Фрейд, это модель. То есть вот, Фрейд делал клинические наблюдения, он что-то думал на эту тему, и он писал какие-то мысли на эту тему. И он создавал вот эти конструкции. Ид, эго, суперэго, вытесненное, возвращается, не возвращается. То есть это не факты, да? То есть Фрейд не знал, что такое гомеостаз. Фрейд никогда не видел МРТ. Вот тот слайд про...
Но Фрейд знал, что такое гомеостаз, когда он говорит в своем произведении по ту сторону
принципа удовольствия.
Да, принципа удовольствия. Он очень много говорит, и он именно говорит про Фехнер, который ввел понятие гомеостаза в физике.
Ну, давайте я не буду спорить с вами. Я цитирую Марка Сомса. Я вам пришлю документы, где формально гомеостаз был придуман после того, как Фрейд создал свою работу. Фрейд мог иметь понятие, но формально, если мы говорим про homeostasis in medicine, Фрейд об этом не знал. Спорить я не буду, я вам пришлю документы, вы их можете почитать. То есть мы немножечко Фрейду приписываем больше, чем он знал. Да? То есть, ну очевидно,
что он сам пишет, что принцип удовольствия, к которому стремится психика, это ввести возбуждение на таком уровне, гомеостатическом уровне, который уже мне не приносит неудовольствие, то есть луст. Но это другое дело, я бы хотел услышать ваше.
Я вам прислал ссылочку, Гига, вы у нас в сообществе есть. Вот в этом посте подробно на этот вопрос, со всеми историями. Концепцию гомеостаз сформулировал Уолтер Кеннон в 1920-х годах, а сам термин он сделал в 1926 году. Да, вот я прислал документ, в котором Уолтер Кеннон придумал гомеостаз. Структурная теория Фрейда была опубликована в 1923 году и разрабатывалась раньше, умер в 1939 и никогда, нигде не ссылался на Уолтера Кеннона. Да? У него было миллион интервью и прочие дела Клода Бернара. Ну, то есть мы сейчас спорить не будем, но вы, так сказать, вот то, что вы говорите, это такая инференция про то, что он знал. Но если формально открыть документы и почитать, то, так сказать, вот гомеостаз научный Уолтера Кеннона Фрейд не знал. Я цитирую вам тоже Марка Сомса, но это, так сказать, дебаты не очень продуктивные насчет... Просто я вас приглашаю прочитать эти документы и посмотреть. Вот. Но еще раз, то есть мы относимся иногда к Фрейду как к фактор. Вот возьмите инфантильную амнезию, да? Мы наблюдаем некоторые вещи, что дети не помнят эпизоды памяти. Да? И Фрейд создал теорию, что они не помнят, потому что оно вытеснено. Но Фрейд не знал, как работает гиппокамп. Вообще. Понимаете? Вот разницу между педнуклеус и стрём.
Дело в том, что да, я хочу вот спорить с вами, потому что это интереснее. Это хорошо, что он не знал, что такое гиппокамп. И даже если бы он знал бы это не дало бы ему ничего. Вот почему. Потому что Фрейд не говорит, что ребенок после 6-7 лет, то есть после первого детства, пока он войдет в так называемый, в кавычках, латентный период, который уже под вопросом, существует ли латентный период, он что говорит? Что ребенок не вытесняет все детские воспоминания, а вытесняет конкретно те, которые заставляли ребенка испытывать неудовольствие. И не просто воспоминания, которые связаны были с неудовольствием, а воспоминания, которые связаны были с инфантильной сексуальностью. То есть, когда Фрейд говорит, ребенок, то есть детские годы покрываются инфантильной амнезией, он не говорит, что ребенок забывает все. И это неправда, потому что есть пациенты, допустим, есть очень много пациентов, которые говорят, я абсолютно ничего не помню с моего детства, а есть пациенты, которые говорят, я все помню, я помню очень яркие воспоминания, когда мне было 2 года, 3 года, я с дядей шел там на озеро и так далее. Но почему? Потому что дело не касается психологии памяти или когниции памяти, то есть памяти, а дело касается конкретных воспоминаний, которые были связаны с фантазматическим миром субъекта, то есть ребенка, и с сексуальностью. Да. То есть вытеснение Фрейда работает исключительно на сексуальность. На сексуальные впечатления.
Не совсем. Но еще раз, то есть, понимаете, давайте вот куда вернемся. У меня есть...
А что касается травмы, вы сказали, что травма вообще не вытесняется. Фрейд сам говорил, проблема травматизма – это то, что оно не вытесняется. Но травматического невроза, они первичных травм. То есть, допустим...
Гега, я очень рад, что мы спорим, но мне бы хотелось, чтобы мы спорили, опираясь на какой-то один, допустим, труд. Можем взять одну статью там, да. Но давайте вернемся вот на что. Есть принципы научного утверждения. Например, если я вам скажу, Гига, что вода...
Да, но психоанализ не наука.
Сейчас, секундочку. Если я скажу, что вода кипит при 100 градусах Цельсия при нормальном давлении, это научное утверждение, оно сформулировано по критериям Поппера, его можно доказать или опровергнуть. Если я вам скажу, допустим, что дети не помнят, потому что они вытесняют, это не научное утверждение. Секундочку. Я просто вот, чтобы приземлиться на какие-то дела. Очень многие вещи, про которые люди спорят, а Фрейд вот так, а Клайн вот так, это верование.
Не, я с вами не согласен.
Сейчас. Подождите. Можно я договорю до конца? То есть если Фрейд говорит, как некоторые утверждения Фрейда очень научные, и их можно доказать или опровергнуть, некоторые нет. Но я вас приглашаю прочитать труды Кристины Альберини, они потратили годы, они исследовали инфантильную амнезию формально, они не просто прочитали Фрейда и поверили в его концепцию, они ее тестировали, они измеряли, да? То есть, и вот я вам скажу, почему его идея неправильная, насчет вычислено, не вычислено. То есть, на самом деле, эпизодические памяти, они укладываются, они быстро забываются. Мы знаем про нейрофизиологию памяти. И вот когда люди говорят, мне даже это все не нужно, это все irrelevant, то понимаете, в чем дело? Тогда мы совершаем клинические ошибки.
Маленькая это... То есть, есть нейрофизиологическая каузальность памяти, то, что я изучал 6 лет в университете, и я взял и все мои книги и конспекты положил в один шкаф, их никогда не открываю. Не потому что нейрофизиологическая каузальность того же эпизодического или биографического или антероградивного, ретноградивного амнезии памяти не важна, а потому что, когда Фрейд говорит о механизме забвения, в своем фундаментальном труде, который основал психоанализ, психопатология обыденной жизни, психопатология de la vie quotidienne, он говорит не нейрофизиологической каузальности памяти, забвения, об психической каузальности памяти. То есть, если субъект забывает книгу, которая была подарена его подругой или соседом и так далее, Фрейд считает, что это совершенно может быть связано с определенным нейрофизиологическим механизмом, но не всегда. И когда это не всегда, это означает, что эта книга и этот субъект, от которого он получил эту книгу, имеет для личности символичный характер. И мы уже заходим в зону психического. и психической каузальности. И вся мерит, как сказать, вся заслуга Фройда в том, что он разграничил нейрофизиологическую, нейрогуморальную каузальность от психической каузальности. То есть, есть две забвения. Есть одна, которая чисто связана. Я могу принять определенные медикаменты, допустим, бензодиазепины, которые помешают мне, чтобы создавался этот нейронный след, который отвечает за память. Оно стирается, потому что я под диазепамом, допустим, да? Но я могу принимать определенные стимуляторы, которые улучшат способность сохранения чего-то в памяти. И, конечно, тогда дело имеется с нейрофизиологической каузальностью. Но когда я проснулся в 7 часов утра, очень много раз повторил свой сон, чтобы его привести к психоаналитику, и когда я прихожу у двери психоаналитика, и этот сон бесследно исчезает, это уже не нейрофизиологическая каузальность забвения, а чисто психическая, детерминированная, не гормонально, гуморально и так далее, а психически. То есть, и все это смешивать нельзя. Когда вы говорите про память, про забвение, это одно, это психология памяти, это когнитивная психология. Есть психоанализ, который совершенно иным образом смотрит на эти вопросы, я думаю.
Ну, Гига, еще раз, я очень рад, что у нас есть разница во мнениях. Это нормально. И дебаты, которые у нас с вами, они происходят у нас постоянно. Но некоторые вещи, которые вы говорите про Фрейда, это ваше мнение про Фрейда. Это
не мое мнение.
Сейчас, можно я отвечу вам, да? У Фрейда, когда вы говорите, что он разграничивает психическое и невро, это не так. У Фрейда это была работа, которая... Сейчас. Вот я вам прислал работу, которая называется New Project of Scientific Psychology.
Это было очень... Это не работа. Он писал флиссус. Эти письма.
Игорь, можно я, пожалуйста, вам скажу, пожалуйста, да, то есть наша вся работа в том, что мы интегрируем, а не разделяем, да, то есть вот как бы одно дело, вы спорите с экспертом по Фрейду, который перевел полное собрание сочинений Фрейда, полное собрание, он его Фрейда изучал по-немецки, да, не по-французски, не по-английски, по-немецки, да, то есть New Project for Scientific Psychology, мы его продолжаем, да, эта работа у Фрейда не получилась, но то, что Фрейд был дуалистом, что он отделял психику от физического, это, так сказать, тоже идеи такие, да. На самом деле, вот я могу вам прислать море цитат про то, что Фрейд был монистом. Если хотите, я пришлю. Но идея в чем? Давайте вот вернемся на клинику. Вот потому что идеологические споры, Фрейд сказал так, что я сказал, это совершенно бесполезно. Возьмем пациента с травмой. Вот я вам привожу клиническую статистику, что 30% пациентов с острым ПТСР не помогает вообще ничего. Ничего, никакая терапия с никакими таблетками. Это строгие формальные РКТ-исследования. Нам надо быть скромными. Нам нельзя плавать в этом нарциссизме, мы аналитики, потому что в некоторых ситуациях мы помогаем очень плохо. С аутизмом мы помогаем очень плохо. И когда мы изучаем новые вещи про то, как работает флешбэк, про то, как работает nightmare, то смотреть на это сверху и сказать, Фройд там 100 лет назад что-то написал, это грандиозность, это нарциссизм, понимаете? Если мне помогут эти данные в том, чтобы работать с этим пациентом лучше и спасти жизни, потому что суицидальность высокая, да, они там героиновые зависимости, то я возьму эти знания, понимаете? Поэтому у нас с вами есть несогласие по каким-то вопросам, но я бы предложил ставить вопросы более специфично и конкретно, да, вот, и я могу конкретно на них отвечать, но это требует усилий и времени. Потому что, другой пример. Возьмите агрессию, возьмите Мелани Клайн. Мелани Клайн на минуточку не закончила университет, между нами девочками. Да, она была очень умным, очень влиятельным человеком, но она университет не закончила. У нее была теория про агрессию, что это первичная вещь, врожденная, inborn aggression. Возьмите другого психоаналитика Хайнца Кахута. У него вся агрессия реактивная, она реакция на какой-то стимул. Но если вы откроете книжку по нейробиологии, вы увидите, что есть и та, и другая, и третья. Это система поиска. И есть горячая агрессия, это система rage. Понимаете, мне не надо идеологических споров, кто прав, Кахут или Клайн. Это бессмысленно.
Нет, это не идеология. Слушайте, Алексей, вот в чем дело. Вы сказали Мелани Клайн, это хороший пример. Есть психология агрессии, допустим, Конрад Лоренц, который изучал все это у животных и так далее, и, Эрнберг, психоанализе и так далее. Давайте отклоним все это, биологический аспект агрессии, который связан с теориями эволюционизма и так далее. У животного тоже есть агрессия и так далее. Человек тоже во время агрессии, то есть инстинкт, самосохранение и так далее. Но Мелани Клайн не имеет дела с агрессией в биологической или в биологической, не в эволюционном смысле. А в первую очередь Мелани Клайн изучает, мы не должны это забывать, фантазии, совершенно архаичные, деструктивные фантазии своих маленьких и больших пациентов. И в таком случае это субъект, который изучает агрессию. То есть Мелани Клайн это не психология агрессии, а Мелани Клайн это психология фантазматической жизни субъекта. И это уже не написано ни в какой генетический код у субъекта. Потому, допустим, Фрейд вначале говорил слово инстинкт, а потом он это изменил словом триб, то есть влечение, так как никаким инстинктом мы с человеком не имеем дела, а имеем дело с денатурализированными какими-то формами, да, которые в первую очередь, и это Лакан говорит, опосредованы языком, так как я субъект языка, субъект символического мира, что Мелани Клайн изучает агрессивные фантазии, а не агрессию, то есть это не психология агрессии, естественно. Естественно, догадки Мелани Клайн совершенно не совпадают с научной формой изучения агрессии, проявления агрессии у животного и у человека. Естественно, что Мелани Клайн катастрофически ненаучная по сравнению с научным исследованием агрессии у человека и у животного. Так как она, Клайн, не изучает агрессию, она изучает фантазматические конструкты своих пациентов. Вот что психоанализ. Что отличает психоанализ от нейробиологии?
Ну, давайте я попробую ответить, если хотите. Да?
Да.
А вот я клиницист. Мне по большому счету все равно, у кого какая надпись на майке. КБТ, гештальт или что. Вот я вам цитирую очень строгое исследование по стандартам Чемберса. Видели мой экран, Гига?
Да.
Значит, это исследование 39 рандомизированных клинических исследований. Это очень серьезно. Которые смотрят на то, что мы с вами делаем, на психодинамическую, психоаналитическую психотерапию и формально исследуют, насколько мы хороши. Понимаете, когда приходит пациент к психиатру, к неврологу, к психологу, ему плохо, он страдает. Да? Депрессия – одна из 10 основных причин смерти в мире. Понимаете, неврологу наплевать, там фантазмы были у Клайн или у Кахута и так далее. Ему важно, так сказать, помочь пациенту не умереть. Да? Вот давайте посмотрим, что они говорят, что наша с вами терапия психодинамическая обладает эффективностью с депрессией, социальной тревогой, пограничными расстройствами личности и гетеромерными расстройствами личности и анорексией. Она для депрессии эффективна с препаратами и без препаратов. Значит, она вероятно эффективна. У нас нет сильных данных про дистаймию, это субклиническая депрессия, осложненное горе, паническое расстройство, общее расстройство тревожное и зависимости алкогольные и наркотические. У нас нет данных для обсессивно-компульсивного расстройства, посттравматического расстройства, биполярного расстройства, шизофрении и расстройства спектра аутизма. Вот это строгие данные, где не верование, там сказать, я лаконист, а я кахутианец. А вот это взяли независимые от нас люди, померили, как эффективно мы работаем. Вот это важно, потому что люди умирают, и люди страдают. Вот ко мне приходят в дверь пациенты, которые суицидальны. Мне надо им помочь, им больно, понимаете? И я возьму любые знания, которые мне помогут. Вот если кто-то клинианец, и он мне там про фантазмы и так далее, но он берется работать за кейс аутизма, и он не помогает ребенку, то это плохо, это некомпетентно. То есть, на мой взгляд, вот то, о чем мы говорим, оно говорит о том, как мне практиковать в зоне компетентности, как клинический психолог. Я должен знать, что расстройства щитовидной железы могут влиять на симптомы моего пациента. Я должен знать, как работает память, понимаете? Для того, чтобы сдать лицензионный экзамен. Я не буду отказываться от этих знаний из идеологических соображений, что у меня на майке написано Лакан. Но я просто хочу сказать, что давайте...
Когда у вас на майке написано что, щитовидка?
У меня на майке написано...
Лакан плюс щитовидка. Не бывает, Алексей, это, то есть, это эпистемологический бардак создает в наших дисциплинах. Извините за такое выражение.
Вы девальвируете вещи, которые вы не знаете на самом деле, потому что Марк Сомс, он...
Я Марк Сомса точно не знаю, а у вас-то на майке он точно написан. Я столько раз Лакана не говорю, я просто говорю, что я хочу сказать.
У меня на майке ничего не написано, но Марк Сомс – это председатель отдела исследований в Международной ассоциации психоанализа. Это 14 тысяч профессиональных аналитиков, закончивших полный институт психоанализа.
То есть вы говорите, что с авторитетами авторитетами не надо говорить, в первую очередь надо смотреть на исследования. А вы сами...
Нет, я просто говорю, Гига, что вы как сказать, ну, я предлагаю, во-первых, у нас с вами мы монополизировали пространство, никто другой не спрашивает. Вот, я предлагаю, если вы хотите поговорить предметно, давайте возьмем паническое расстройство, давайте возьмем острую травму, и мы поговорим. Вот фантазмы Клайн помогают этим пациентам или нет? И на каком основании, и вот на чем будут основаны данные про Клайн, что клинианский анализ лучше для этих пациентов или нет? Вот для меня в этом суть.
Я могу вам спросить вот что.
Да.
Допустим, пациенты, не все, конечно, но только одна часть пациентов, процентно я ничего не могу сказать, так как у меня клиническая практика, я статистику не делаю, но, наверное, где-то 30-35% моих пациентов, которые страдают паническими расстройствами, что не является диагнозом, давайте скажем так, потому что паникой может страдать субъект, который имеет невротическую структуру, паникой может страдать субъект, который имеет обсессивный невроз, паникой может страдать бордерлайн, конечно же, паникой может страдать субъект, который во время предпсихотического состояния вот-вот получит психоз и так далее. То есть паника – это симптом, который может, ну, у некоторых оно повторяется. Вот. И очень часто, где-то, наверное, 30-35% с пациентами очень эффективны медикаменты, так называемые анксиолитики из групп бензодиазепина или же какой-нибудь трициклический антидепрессант. Они иногда настолько эффективны, что можно просто восхищаться этим. И это очень хорошо, что они эффективны, и это очень хорошо, что это дает огромнейшее облегчение пациенту. Но это означает, что панический приступ имеет свой, так сказать, церебральный, нейрогуморальный и нейрофизиологический субстрат. Но это совершенно не мешает нам задуматься о психологической, о психической каузальности паники, невзирая на то, что головной мозг, естественно, участвует во время страха, так как страх – один из самых древнейших эмоций, которую я могу испытать в эволюционистском смысле. Так что, когда вы говорите, что да, паника – это все, да, исследованием, естественно, доказано, что во время паники очень сильно вырабатывается гормон норадреналин, адреналин и так далее. Это доказано, об этом никто не спорит. Но меня интересует вот что, когда вот такой клинический случай с паникой.
Могу я ответить на этот вопрос?
Да, с паникой. Такой клинический случай. Пациент сидит, ждет своего поезда. Он открывает сигарету, пачку сигарет. У пачки сигарета есть такая лента, которая клеится. Те, которые курят, это хорошо поймут. И он наматывает на палец эту ленту, считайте, как скотч, которым приклеен был сигарет. И он не может, вдруг он теряет то есть концовку этого лента, и он не может с пальца сорвать эту ленту. В этот момент он испытывает чувство полной беспомощности и включает панику. Естественно, нейрогуморальный механизм в этом включен. Но почему он включает панику тогда, когда вдруг его палец оказывается в полной безвыходности? То есть он берет ключ от машины и чуть не отрезал себе палец, лишь бы освободиться от этой ленты. И вот тут ставится вопрос, как ответить на это.
Ну, Гига, могу я вам ответить, да?
Да.
Да, просто у меня ощущение, что, так сказать, может быть, вы хотите многое что сказать, но я не знаю, нужен ли я тут, да, то есть вы уже, если все знаете про панику. Дело в том, что паника и страх – это две разные системы. Вы упомянули норадреналин. В паническом реакции есть две разные тревоги. Есть система расставания, это паника, есть система fear. Вот норадреналин – это fear, а в панике миопиоиды. Вы не совсем как бы точно
адреналин
физиологически, да? Нет, не адреналин, а миопиоиды, там другая реакция. Да? То есть вот на панической это не совсем тот страх, что я сейчас умру. Если я вижу акулу, у меня другой страх, чем когда у меня паническая атака. Паническая атака – это реакция на потерю. и, так сказать, там другая химия, анатомия, все остальное. Но и вот эмпирические случаи из жизни мы можем брать какие угодно. Мы можем взять случаи, которые все читали, случай маленького Ганса. Вот теория Фрейда про то, почему у маленького Ганса была фобия лошадей. Если мы про фобию это знаем, вы меня простите, но есть Джозеф Леду, есть очень много исследований фобий, да, и вот, так сказать, вот мы знаем, как она работает, когда работает, что такое реинстейтмент и все остальное. Но, понимаете, Фрейд же был неплох, он ошибался, да, вот в некоторых вопросах он ошибся, в некоторых вопросах он был не совсем точен, в некоторых он был абсолютно точен, да. И вот по поводу того, что он объясняет, почему у маленького Ганса сформировалась фобия лошадей и почему ему стало лучше, мы можем поговорить, что он был не совсем точен, да. Больше того, он работал с папой маленького Ганса, да, а не напрямую с пациентом, он, так сказать, давал советы и так далее. Ну, в общем, там море есть о чем говорить, но паника – это прекрасная вещь. Да? Я согласен с вами, что панические эпизоды – это не диагноз, они могут быть у кого угодно. Я могу индуцировать панический эпизод электродом, они могут случиться в случае, так сказать, у малыша и так далее, но как с ними работать и что делать? Мы работаем мы работаем с тем, чтобы вернуть систему паники в регуляцию. Мы смотрим, как она стала дисрегулированной, какие потери человек испытывал и так далее и тому подобное. А медикамент, что делает медикамент, когда у меня прямо сейчас паника, у меня бьется сердце, у меня потоотделение, он просто глушит габа, идет габа, да, и она меня просто подавляет, да, она мне выключает всю, так сказать, активизацию. Он гасит эпизод, но ничего не делает с причинностью паники. То есть система по-прежнему дисрегулирована, поэтому когда мы говорим, что препарат эффективный, симптоматически, препарат эффективен, чтобы подавить эпизод паники, но не эффективен с тем, чтобы снять причину. Мне кажется, у нас задала Мириам Калибашвили. You're asking, my first question is how to translate scientific data into specific psychotherapy techniques. And the second question, how memory consolidation, reconciliation I explained by neuropsychoanalysis, right? Good question. So should we discuss that or should we stay with other things? Psychotherapy techniques, right? So there are different things that we talk about in dynamic therapy: containment, interpretation, confrontation, and other things. Well, first of all, the difficulty with psychodynamic therapy is that you cannot manualize it. If you're practicing true psychodynamic therapy, you cannot write a manual on how to do it because a lot of things are not as structured. You can manualize EMDR, you can manualize CBT. And I will post in the chat a framework by a prominent analyst, Jonathan Shedler, about evidence-based, right? But what we can say for sure is, first of all, we can formally study how we dynamically work with specific disorders. And I've posted one of the studies in this link. By the way, there's 2 pages of research that I've posted, formal research on the efficacy of dynamic therapy with specific conditions and specific populations. We're not good with everything. As I said, we fail 30% of the time with acute trauma. We don't help all that much, despite Ann Alvarez with autism. But what we can do is, by incorporating scientific evidence, we can update our models, such as update of the model with acute trauma, and we can help those patients better. And we can rule out and we can refer patients to other therapists and other clinicians as necessary. But the best answer to your question is clinical workshop that Mark teaches. For neurotic conditions, not for borderline, not for psychotic conditions, for neurotic conditions, we formally study, how specific techniques make it better. And the second question is how memory consolidation and reconciliation are explained by neuropsychoanalysis. So these are neuroscientific terms, okay? And we use them in the model that we've built. But anytime when your patient in your session of psychotherapy recalls an episode of life, it opens the memory and it becomes labile, and then they can put it down. When they put it down, you can modify the memory. You can make it weaker. You can modify some details. And this is the intervention in psychotherapy. Reconsolidation happens in every single psychotherapy session. And so it's crucial, but not every memory is accessible for reconsolidation. There's memory age. Recent memories are available for reconsolidation. Old memories, your 7th birthday is not available for reconsolidation. Okay, memories that are forgotten are not available for reconsolidation, but we definitely use this construct because that's exactly what we do in therapy sessions. I don't know, Miriam, if I answered your question or not. But these are vast topics that I don't know if we'll have time to dive into in details. Remembering, forgetting, and Yeah, I've posted the course by Christina Alberini. This is the researcher in memory consolidation on our platform. It's a very introductory level course, and she defines the construct. She defines what it is, how it works, when it doesn't. You can read everything you want about memory reconsolidation and consolidation. But again, acute episodic trauma memory, you cannot reconsolidate. It's just not there. That's the difference. You know, the episodic memory is not there. Procedural is there. Semantic is there. Might you have any other questions? Anna says, thank you. You're welcome.
Can I ask a question?
Of course. Yeah.
My question is about the formulations you showed us after like discussing Melaniclane's.
I apologize. Would you introduce yourself and speak up a little bit? I can barely hear you.
Okay, my name is Kaha. I am a practitioner psychotherapist in Georgia, and I'm using psychotherapy. So yeah. My question goes as when you mentioned can you hear me?
Not well.
Okay.
არის მის არა
აი
ახლა შედარებით აბა
უკეთესია
შედარებით უკეთეს
ახლა
Yep.
Can you hear me now?
Yes.
Yeah. When you mentioned Melanie Klein and her work with her positions like depressive and manic positions, you said that those are quite limited numbers of positions, like 2, and you've mentioned there are more divergent positional states. I'm interested what did exactly you meant, because when Melanie Klein spoke about those positions, she did not only spoke about those 2. Yeah, those are the main positions, but deeply speaking, she talked about much more states in those positions, even like substates with many. Even Oedipus, there is Oedipus, right? Because it's for Melanie Klein it was very early. For Freud, it was late thing. So Melanie Klein thought that it was very early with mother, with the connection to breast and how breast was evil and how breast would bite the child or child bite the breast. So my question is that what did you mean that Melanie Klein's position were limited? And
yes. Yes. So it's a vast topic again, and again, Melanie Klein is much more complex. I did a straw man out of Melanie Klein to mention it, but and she has her own developmental idea, and she talks about babies. There's a Kleinian baby that analysts study, Freudian baby, etc. And prior to the baby recognizing that mom is a separate object, that mom may have her own feelings, the baby operates in a paranoid schizoid position, and then the baby may acquire depressive position, which is ambivalence, which is understanding that the mom whom you love is a separate human being. And then in adulthood, you can see a patient operating in a paranoid schizoid position where they split, where they're very concretely sure of them being right. They have no doubt whatsoever about their confidence, and then in depressive position, there's ambivalence, right? So of course, there's nuances and shades of gray, anything, but it's a categorical style of thinking. It's buckets, right? So take temperature, for example, Kaha. So if I measure temperature, it's a continuous variable, 36, 37, 38. If I tell you to measure temperature in categories hot and cold, then you will create an artificial boundary of 38 degrees Celsius between hot and cold, or hot and warm. And this is a mathematical distortion because you're dealing with a concrete variable. You're creating a boundary where none exists. Take a neutral state, such as contentment, which is not a depressive position or a paranoid schizoid position. There is no space in that. I don't think Melanie Klein knew the difference between the episode of psychosis and schizophrenia or a manic hypothesis versus a schizophrenic hypothesis. There's just the colors that she allows you to draw with are insufficient for the modern clinical practice. You know, take autism. Tell me anything about autism in Melanie Klein's standard theory. You know, tell me anything about dyslexia, right? So if you look into the physiology and the development of a child, it is much more complex and nuanced. There's basic arousal, which is a continuous variable. Of course, we can be in different states, and a child can be in the state of paranoia temporarily. They can be in the state of ambivalence, but they can also be in a state of play. They can be in a state of, you know, many other states that don't fit into 2 buckets or 3 buckets, okay? And while within each bucket you can have more water or less water, you still apply categorical thinking on something that did you see the video that I showed with the brain, you know, of how dynamic and how intertwined things are and the global phenomena and local phenomena? What do I do with 2 positions and this video? Okay, how do you fit this video in these 2 positions? I'm just suggesting that the level of mathematics necessary should be much more sophisticated than a choice of 2 or 3 options, right?
Yes, the reason why I'm asking you is that because after that you showed us the 7 main feelings.
არ ვესმის.
ახლა ცუდად ისმის.
ეხა ისმის?
კი.
The reason why I'm asking you that is that after that you showed us that you discussed 7 main, I would say, feelings, and they were lost, they were like desire, etc., etc. So we are not, so if I'm getting it right, we are not categorizing it in 2, but somehow we are categorizing it in 7. So how is it different between it? Because Melanie Klein's things were not 2, I think, what I'm reading from Melanie Klein, but there are many things, like more than 7. So why are we saying that it's the buckets for Melanie Klein for categorizing the 2 main states, but we are not saying the thing that it's similar with the 7 states, like lust, like love, like hate, and etc.
Sure.
I don't
Very good
think that's
question.
relevant. I mean, I don't think that's relevant right now, what you're saying, because I think, I'm sorry for just butting in, but I think he just said that to demonstrate a point and not just to get into the whole Melanie Klein theory, because as you said, and I agree that sometimes people tend to get too hung up on the theories and the frameworks, and this is what's happening basically right now with, I mean, it's not the point that he was trying to get into, I think, and by discussing this, we're kind of losing the time we could use more efficiently. I'm sorry for just chiming in, but that's how I felt.
Yeah, I appreciate for your comment, but I'm available. I wrote my email here. I'll be happy to talk to either one of you in more details. These are vast topics on Skype or WhatsApp, anything. We have a Facebook group. We have many meetings, and you know, I have a patient soon, so I'll have to say goodbye, but I'm available to dive into details. And to briefly answer your question, Kaha, is 7 buckets. They are indeed buckets, and buckets exist. Please don't get me wrong. I mean, I used to study physics very seriously. Dead or alive are buckets. Pregnant and non-pregnant are buckets. There's no such thing as 15% pregnant, right? But, you know, continuous variables also exist. All I'm saying is use the appropriate level of modeling for the phenomenon you're studying. If you're studying, you know, James Webb Telescope, don't approach it with algebra. It's not going to be enough. We have a subject that is much more sophisticated, and we're describing it mathematically with tools that are not necessarily applicable. And I just gave some illustrations there. Thank you so much. And the theory that we study, I haven't a chance to give you all of the account. We use generalized arousal, which is a continuous variable. We have 7 instincts, and each one of them is a 3-tier hierarchy, as I said, with top-down and bottom-up influences. And the very topic you bring up is something that I argued with Mark Solms on our recent Congress. I actually made that point. I said we moved from 2 buckets to 7 buckets. He wasn't very pleased with my statement, and I'm actually incorporating chaos theory framework, mathematical chaos, not you know. So we have a living and breathing model, but The idea is to test the data scientifically and to see how good we do business, how well we help our patients. If something gets better, if less people die from suicide, I'm happy. That's my only goal, you know. Instead of sort of walk around to say I'm a hardcore Kleinian, there are debates, hardcore Kleinians arguing with Mark all the time, and exactly they say the things like, you haven't given us anything new. Everything you're saying is available in the work of Melanie Klein, which is factually incorrect. And they're saying we don't need this at all. We have been successful. You know, historically, psychoanalysis didn't even do any research whatsoever. This is why CBT became so prominent. We were so sure of ourselves that we didn't verify how well we work for a long, long time. And suddenly we started doing the randomized clinical trials, meta-analysis, longitudinal studies, and realized that we're not as good as we thought we were, and we need to do better. And again, Freud predicted that this would happen, and this is what is happening now. IPA is fully on board, the most prominent organization of psychoanalysis in the world. Look at Chicago Psychoanalytic Institute, New York Psychoanalytic Institute, London, Johannesburg, Paris, Bonn. They're all joining the neuropsychoanalytic field. Some people don't, and that's totally fine. It's a choice. This is one of the ways we can develop future if you want to, and if you don't, it's okay. So, but maybe we should. Yeah.
Еще один такое учение. Мелани Клайн говорил Каха и Ариам, наши коллеги. Это, по-моему, очень сложный вопрос научности психоанализа. Вы отметили Поппера, который критиковал психоанализ, потому что психоанализ не наука, потому что невозможно опровергнуть его, так сказать, доводы. Но вот про Мелани Клайн. Очень много концептуализаций у Мелани Клайн, клинических и теоретических, основывается исключительно на не просто клинический опыт, а на психоаналитический клинический опыт. То есть этот был человеком, который работал с пациентами исключительно психоаналитическим методом. И только таким методом она могла иметь доступ к определенным психическим формациям. Допустим, скажем так, есть миллион, но скажем одно, Мелани Клайн думал, что ребенок в своих архаичных фантазмах очень сильно боится, это очень архаичный страх, встретить в чреве матери, в животе матери деструктивный пенис отца. То есть, если мы читаем Мелани Клайн, 90% это. Никакой исследователь сегодня ни в Штатах, нигде, ни в России, ни здесь, в Грузии, никак не может верифицировать научно-эмпирическим методом 90% доводов Мелани Клайн. Не потому, что они не научные или клинически необоснованные, потому что метод исследования психоанализа фундаментально отличается от метода исследования точных наук, то есть от эмпирического метода. Почему? Потому что невозможно исследовать бессознательные процессы путем эксперимента. То есть невозможно путем эксперимента доказать, что означает фантазм деструктивного пениса отца в животе матери. Вы понимаете? То есть мы не то, что находимся в идеологическом споре, но фундаментально это неразрешимая вещь, если мы будем идти по пути. Я назвал бы немножко параноиальным идею проверить и подтвердить, то есть верификацию теории Мелани Клайн через экспериментальный метод. То есть экспериментально исследовать пациентов, есть ли у них фантазм деструктивного пениса отца в животе матери. Это невозможно.
Я прошу прощения, у меня просто пациент ждет, и поэтому я должен попрощаться, буду скоро. Я хочу сказать, что по поводу мнения, что психоанализ весь в корне ненаучный и проверить невозможно, это ваше мнение, Гига. Я вас приглашаю прочитать труд, который называется Scientific Standing of Psychoanalysis. Там подробнейшим образом, деталь за деталью, рассказывается, что научно, а что не научно. Тут нужно нырять в детали.
Да, Алексей, мы сегодня здесь в Зуме, вы нас представляете всегда каким-то трудом. Вы можете прямо ответить, как я.
Я
вам пример привел Мелани Клайн. Вкратце, если можно.
Да, я могу сказать, что надо начинать с утверждений, что пенис – это не научное утверждение, поэтому, разумеется, его нельзя доказать. Утверждение, что Бог есть, невозможно…
Вся психоанализ строится на пенисе фаллос.
Нет, не вся. Давайте.
Я анекдот расскажу. Вы знаете, есть такой психоаналитик французский.
Вы простите, что я присылаю документы, но я не хочу упрощать для инфузории туфельки, вещи, которые сложные. И если вы откроете и прочтете, это займет 20 минут. Там написано подробно про научность. Но мне в самом деле, меня ждет пациент, я должен попрощаться. Огромное всем спасибо, что пришли. Я написал свой email в чате, если какие-то вопросы. Thank you, everybody, for joining us. I apologize for speaking in Russian sometimes. I'm available. There's Skype, email. You can check our association if you want to. No pressure. There's no expectation whatsoever. But I look forward to talking to you more, debating, arguing, having heated discussions, not heated discussions. These are very interesting topics, but I do need to go now. Thank you so much, everybody. Bye-bye.
Thank you.
Thank you.
Thank you. Bye-bye. Bye-bye.
Thank
Bye-bye.
you. Bye.